check. Okay. So we will start now. Okay. So welcome all. Please mute yourself, but always show your video picture. Sign in your name, FB account, or email address in the chat box. Include names of companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and end of the pep talk. As a reminder, please take the online learning comb evaluation test exercise or Indirect learning and have a perfect score to get a certificate. The link will be in the chat box by Abed. Okay, so this is the sample of the certificate. As a reminder also, getting 50 or letter certificates will entitle one mentee to a voucher for free ROJoson telemedical consultation. So let's now have a group picture taking before we start the lecture proper in 2 minutes. Please show your face. Okay, 1, 2, 1, 2, 3. Okay, you can start. Okay. I have a patient empowerment program which I'd like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the core course on October 9, 2021. I'm now on health disorder courses. This may take about 3 years or longer to finish, including the health issue courses. My pep talk today is entitled Fundamentals and Generalities in Medical Management of Breast Cancer, Part 1. This is part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of breast cancer. Some definition of terms in the title and delimiting the coverage of my talk. When I say fundamentals, it means simplest essential facts and theories which can serve as basis or foundation and support for advanced or more information in the future. Generalities to mean general statements of information, not covering specifics and not too detailed. Medical management means diagnosis and treatment of breast cancer as being done by majority of the physicians. I will be covering part 1 for today. So the contents will be screening for breast cancer, symptoms that will lead to suspected presence of breast cancer, clinical diagnosis of breast cancer, and paraclinical diagnostic procedures for breast cancer. Let's start with screening for breast cancer. Screening for breast cancer means looking for breast cancer that may be present in apparently healthy and asymptomatic persons, particularly females. Breast cancer is more common in females than in males. It's very uncommon and even rare in males. But breast cancer can also occur in males, okay? Only 1% in males, at a ratio of 1 male to 100 females. So usually no more screening in males because breast cancer is rare in this sex. This is an application of the principle of medical screening, which is to screen only in high-risk situations, particularly common and high incidence. The 3 general screening procedures being done for breast cancer as well as for other cancers in general: risk assessment interview or evaluation, Second is risk assessment interview with physical examination. Then the third is risk assessment interview with physical examination and with the use of instrumental or laboratory diagnostic procedures. The first screening method is risk assessment interview or evaluation. Here we look for higher risk for cancer, breast cancer in a particular person or patient. Specifically, we look for history, family history of breast cancer, and risky lifestyle and behavior such as tobacco use, alcohol use, obesity, use of hormones, exposure to excessive radiation, etc. If positive for higher risk in the risk interview evaluation, one can proceed to the symptom and sign evaluation, such as physical examination, and if indicated, do the instrumental or laboratory diagnostic procedures. But if negative for higher risk upon interview, you may stop here or proceed to sign and symptom evaluation, which include interview and physical examination, just to complete the basic essentials of screening. So the second screening method is the so-called risk interview and physical examination. This is actually the basic essentials of screening. If positive upon interview and physical examination, and then there is a positive for higher risk and with suspected presence of cancer based on symptoms and signs, proceed to instrumental or laboratory diagnostic procedures as indicated. If negative on interview and physical examination, and with no suspected presence of cancer symptoms based on symptoms and signs, one can stop here. The third screening method is interview, physical examination, then with the use of the instrumental or laboratory diagnostic procedures. Do only instrumental laboratory diagnostic procedures if positive for higher risk for cancer, for example, positive family history of breast cancer, and or if with suspected presence of cancer based on symptoms and signs. So in this era of commercialism in medicine and medical care, beware of a lot of hospitals and laboratory clinics peddling screening packages for cancer. Don't be swayed easily by the marketing and discount offers. In the Philippines, currently there is no official nationwide breast cancer screening available. When you say no, it's no official, no formal. Okay. So the Philippine Breast Cancer Control Program just emphasizes the importance of annual CBE or clinical breast exam from the healthcare professionals like the nurses, doctors, and public health physicians and midwives, and monthly breast self-examination. In the Philippines, even though if there is no formal program, the medical societies, hospitals, clinics, and individuals, physicians are advocating the following: mammogram starting at age 40 and annually, breast self-examination, and clinical breast examination. Oftentimes, ultrasound of the breast is added as part of the screening. This is very rampant. Okay. As to the international societies, such as the American Cancer Society, these are the guidelines for screening of breast cancer. Women aged 40 to 44 should have the choice to start annual breast cancer screening with mammograms if they wish to do so. Women aged 45 to 54 should get mammograms every year. Women 55 and older should switch to mammograms every 2 years and can continue yearly screening. Screening should continue as long as a woman is in good health and is expected to live 10 or more years or longer. All women should be familiar with the known benefits, limitations, and potential harms linked with the breast cancer screening. And women should also know how their breasts normally look and feel, and report any breast changes to a healthcare provider right away. This is what is called the so-called breast self-examination. For women at average risk of breast cancer, screening mammography is recommended every 1 to 2 years, beginning at age 40 years old. If you have not started screening in your 40s, you should start having mammogram no later than age 50. Screening should continue until at least age 75 years old. So these are the recommendations of the American Cancer Society. The US Preventive Services Task Force and the Canadian Task Force on Preventive Healthcare have somewhat different guidelines. Mammography every 2 years between age 50 to 74. For Canada, it's 2 to 3 years. For women aged 40 to 49, guidelines advocate an individualized approach, okay, in which the clinician should base decisions on potential benefits and harms of mammography and the woman's preferences and her breast cancer risk profile. My personal recommendations: breast self-examination monthly starting at age 20 and onwards, clinical examination of the breast by a breast specialist clinician every 1 to 2 years starting age 30, and mammography, if it has to be done, every 2 to 3 years from age 50 to 74. When you say breast cancer specialist or breast specialist physician in the Philippines, usually we refer to the board certified general surgeons because they have extensive training on breast palpation. Now let's go to symptoms that will lead to suspected presence of breast cancer. These are the usual alert symptoms or symptom cue for breast cancer: breast mass, change in breast contour, nipple retraction, nipple areolar skin erosion, nipple discharge, usually red, and armpit mass. Okay, so the question is pain also a symptom cue for breast cancer? The answer is pain per se, without the above associated alert symptoms, all of this is not a symptom cue for breast cancer. So I will be discussing this later on in the part of the clinical diagnosis of breast cancer section. So let's now go to the clinical diagnosis of breast cancer. Clinical diagnosis means a conclusion or decision made by a physician after examining a patient and after evaluation of the data on symptoms and signs. Symptoms are what are felt and observed by a patient or a person on her body. Signs are those findings of a physician after the physician has done a physical examination of the patient. So the procedures or process in the clinical diagnosis of breast cancer, it starts with patient presenting to the physician with symptoms, and then the physician evaluates the symptoms to see if these symptoms are alert signals or symptom cues for cancer or not. And then the physician does physical examination to look for sign cues for cancer. And after that, the physician processes the data, the symptoms and sign to determine whether cancer is present or not, or this is what is called clinical diagnosis. Okay. So the endpoint will be a conclusion, decision whether it's not cancer, cancer suspect, probable, or most probable. The processes used by the physician in the clinical diagnosis of cancer, usually pattern recognition and prevalence with priority on pattern recognition. Pattern recognition process means realization that the patient's presentation of signs and symptoms conforms to a previously learned picture or pattern of a disease. Prevalence means choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age group, sex group, and in the affected organ or system. So remember the definition and behavior of breast cancer when looking for pattern recognition in the alert symptoms or symptom cues. Remember this definition of breast cancer. It's a medical disease when some of the breast cells grow uncontrollably with the potential to invade the adjacent body and tissues and to spread to distant tissues or organs. Suspect cancer in the breast mass with cues of invasion of adjacent tissues, such as ill-defined border and fixation. Suspect cancer in the breast mass, patient with a breast mass with cues of spread to the armpit, the lymph nodes, and to distant tissues or organs like the bone, the lungs, the brain, and the liver. So these are the common alert symptoms, but the most common is the breast mass. Okay. Once you have a breast mass, you have to see whether it's associated with all these changes. Okay. The foremost in the physical examination being done by the physician and also probably by the lay people, you can do this, okay, is once you feel something that could be a breast mass, so you look for a dominant mass, a real mass, the so-called real mass, the mass which is considered as the red flag, meaning if present, it needs at least more investigation. One should distinguish dominant mass from prominent or irregular or unsmooth breast tissues, which are usually part of fibrocystic changes and which is considered normal and does not require surgical treatment. So this is an illustration of what I just said. Okay, so lumpy breast, okay. No dominant mass. Dominant mass is described as one that stands out with very different from the surrounding tissues. Okay, so this is the red flag for breast cancer. But if you have just this lumpy breast, it's fibrocystic changes, normal breast. Okay. So clinical diagnostic algorithm in patients with no dominant mass. Let's start with the no dominant mass. No dominant mass found on physical examination in patients complaining of breast mass. Sometimes patient complains of breast mass, but on physical examination, there's really no dominant breast mass. And in patient coming for a breast check. Okay. So the diagnosis is normal or fibrocystic changes. Now, the patient has pain, breast pain, but with no dominant mass, the diagnosis is fibrocystic changes, not breast cancer. In patients with non-sanguinous, meaning not red nipple discharge, but with no dominant mass, the diagnosis should be fibrocystic changes or hormonal changes. Okay? If the discharge is red or sanguinous, but no dominant mass, the diagnosis is intraductal papilloma, which is benign. No dominant mass, but there is a focal redness or erythema and tenderness. Okay, the diagnosis is mastitis or infection of the breast. This is the common algorithm that I use in the clinical diagnosis of breast mass. If there is a breast mass already, dominant mass, okay, I look for signs of inflammation first. If it's positive, your diagnosis should be infection or inflammatory mass. And if negative, then the choice is between malignancy and non-malignancy. Okay, so first look for signs of malignancy. If positive for signs of malignancy, the diagnosis should be automatically malignant tumor. If negative for signs of malignancy, then you can settle for signs benign tumor or look for signs of benignity. So diagnostic algorithm for a patient with a dominant mass this time. Okay. So as I said, First, look for signs of inflammation and infection, which consists of pus, if present, erythema, redness, tenderness, fluctuancy, or depressible wall of the mass. If present, any of these if present, the primary diagnosis is inflammatory or infectious mass. Okay? Since there's a mass, we call that abscess. If there's no mass, earlier I mentioned about mastitis. If there's no mass, you call it mastitis. But if there's a mass, it seems that there's pus inside, then we call that an abscess. If no signs of inflammation and infection are present, then we have to decide whether the tumor, the mass, is malignant or benign. So first, look for signs of malignancy. Some signs of malignancies are the following, okay, which actually signify local invasion and also spread. Okay, so signs of local invasion can be ill-defined border, fixation, retraction, ulceration, fungation. Okay, signs of spread would be there's the presence of the axillary lymph nodes or other distant mass. Okay, so if present, any signs of malignancy present, suspect malignant tumor. If no signs of malignancy, more likely the mass is benign, especially if the mass is cystic, which means containing fluid. So for nipple discharge, determine whether it's sanguinous, non-sanguinous, or sanguinous. If non-sanguinous, no mass, as mentioned earlier, fibrocystic changes. With a mass, then you have to evaluate based on the mass that I just discussed earlier. And then if sanguinous, no mass, intraductal papilloma. If with a mass, then it's cancer until proven otherwise. So, as I said, breast mass is the most common presenting alert symptoms or symptoms due. You have to evaluate the mass and then look for the other changes. Are there associated change in breast contour, nipple retraction, nipple areolar skin erosion, okay, red discharge, armpit mass? If any one of these is present, suspect cancer, breast cancer already. So what are the physical examination findings on the breast that will raise suspicion for breast cancer? This is, I just repeat this for emphasis. Presence of a dominant mass, breast mass, with telltale or giveaway signs of malignancy, which consists of signs of local invasion and signs of spread. And then the other scenario, the other situation is that you have the presence of red nipple discharge with an accompanying mass. Signs of local invasions of the breast mass includes the following. If there is fixation to the adjacent tissue, such as the overlying skin, okay, of the nipple and areola, and the underlying tissue, such as the chest wall and the ribs, which make it not movable. Skin changes over the mass that is suggestive and indicative of local invasion of the skin, such as ulcerations and fungations. Signs of spread. Signs of spread to the pulp, to the axillary area. Okay. Same side. If there's a mass here, if there's a mass there, so that could be a sign of spread already. Okay. And then if there are lymph nodes on the above the neck, which we call supraclavicular lymph nodes. So these are signs of spread. If present, we suspect breast cancer already. So examples of symptom sign cues and use of pattern recognition and prevalence in the clinical diagnosis of breast cancer. 30 years old and above, older, with palpable breast mass, but the mass is solid. Okay. The first scenario is the mass is solid, but it's not fixed. There's no armpit lymph node. So at this point, just this one, you have a breast cancer suspect. Now, if the mass, the solid mass, is also fixed, okay, without lymph nodes, then the diagnosis is breast cancer probable. Okay? Higher degree of suspicion now. Now, if the solid mass, the fixed mass, has accompanying armpit lymph nodes, the breast cancer is most likely present or most probable. Okay. Any patient with any age with palpable breast mass, cystic, okay, containing fluid. So this patient is not a breast cancer suspect. The diagnosis is benign. To be more specific, you can call it macrocyst because it's palpable, it's a big cyst, and then it's due to hormonal change. Any age, palpable breast mass with redness, tenderness, possible pus. No, not a breast cancer suspect, benign. Specifically, it's an infection. If there's a mass, it's an abscess. So to repeat the processes in the clinical diagnosis of breast cancer, patients presenting with symptoms first, then physician evaluates the symptoms to see if these symptoms are alert or signals or symptom cues for cancer or not. Then he does the physical examination, look for sign cues, and then he processes the data, symptoms and sign to determine whether cancer is present or not. He makes this decision, possible conclusion that may follow after the examination, not cancer, cancer suspect, cancer probable, cancer most probable. The next thing for the physician to decide is whether to do paraclinical diagnostic procedure or not. Okay. Whether to do instrumental or laboratory diagnostic procedure after the clinical diagnosis. So we now go to the paraclinical diagnostic procedure for breast cancer. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis and you need to be certain and be more certain before treatment, then go for a paraclinical diagnostic procedure. To decide on the indication, the physician uses two processes: degree of certainty on the primary clinical diagnosis and comparison of treatment plans for the second primary and secondary clinical diagnosis. As a rule, there is no need for a paraclinical diagnostic procedure if you are quite certain of your primary clinical diagnosis and the treatment plans for the primary and secondary diagnosis are the same. If there's a need for a paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit, R stands for risk, C cost, and A availability. The physician gives or lists down the various options for the paraclinical diagnostic procedures and then gives data on the BRCA. With the data given, usually the patient should be asked what she prefers first before the doctor will make a prescription or make a decision on what to do. Examples of BRCA comparative analysis of the paraclinical diagnostic procedure: option 1, 2, 3, accuracy 99%, 90%, 60%. If the risks are all acceptable, assuming, and then the cost is 4,000, 3,000, 1,000, then assuming or available. So if you look at all this data, if I were the patient, I would choose option 1 if I have 4,000. If I don't have 4,000, I'll get number 2, okay? Because 90% is still good enough, okay? There are several issues to discuss in the selection of paraclinical diagnostic procedures to be done for suspected cancer. There are a lot of confusion going on, okay? That's why I want to bring this out, okay? So using the FAD, the popular one without comparative analysis of benefit, risk, cost, availability, and other options, usually with no consideration of the cost effectiveness and patient preference. This is not recommended. Shotgun approach, ordering every possible test just to catch the diagnosis. Again, it's not recommended. Ordering tests, definitely ordering tests not needed for the diagnosis. It's also not recommended. The two other issues which I have to discuss are the primary and secondary indications, and then direct and indirect investigations of the suspected cancer. When you say primary indications for the paraclinical diagnostic procedure, this refers to the indications, to the direct information that you need to have on the tumor, okay? Whether the tumor is a cancer or not. Okay? So primary indications will be not quite certain of the clinical diagnosis of the cancer, just a suspect or probable. And then the other indication is that you need to be very certain in the diagnosis of the cancer because an extensive complex treatment procedure is being planned. This is the first priority, the primary indications. There's such thing as secondary indications. These are usually done to get other information in the planning if there is already cancer. Okay, this is on top of the after the first primary indications. So secondary indications include the following. After you know that you have a breast cancer, you still need to know before treatment the extent of the cancer and other information such as the specific cancer type and the prognostic examinations that will help you make some useful decisions. As to the direct and indirect investigations, okay, direct means done on the primary, suspected primary cancer lesion, such as lesion, biopsy of the lesion, biopsy of the breast mass. Okay. Indirect means done outside the suspected primary cancer lesions, okay, such as, let's say, biopsying the lymph nodes on the axilla, okay, not the breast mass itself, okay, such that if the breast mass, the axillary lymph nodes is positive, it can infer cancer on the breast mass. Okay, so both approaches can be done as dictated by situation, but usually we do the direct examination first. Okay, so do the second approach only if the direct approach is not feasible or difficult. Examples of physicians ordering for paraclinical diagnostic procedures: shotgun approach. They order all of this at the same time: ultrasound, mammography, CT scan, tumor markers, bone scan, ultrasound of the abdomen, PET scan. Okay, this is for patient with a palpable breast mass. Okay, so you can see when they do ultrasound of the abdomen, this is indirect examination. Okay, so the recommended approach would be to do a targeted, sequential with prioritization approach. If there's a breast mass, examine it first through biopsy or ultrasound. And then, if positive, then you do the other test to check the extent of the cancer. Examples of BRCA: comparative analysis of paraclinical diagnostic procedures in a patient with a dominant breast mass. Okay. So usually these are the common options that are being practiced in the country: biopsy, ultrasound, mammography, CT scan. Okay, some would include MRI. Okay, so in terms of benefits, okay, so biopsy, since it's a direct attack on the tumor, okay, you have direct information, and the yield should be the highest. Okay. Ultrasound, mammogram, CT scan, these are imaging technique. No? So this is not a direct examination of the tumor. Okay, so the information that will be gotten from these three examinations: CT scan has the highest, mammo, this is for, we're talking about breast mass, mammo has the least, and then ultrasound has the second. Okay. So in terms of risk or inconvenience or pain, okay, biopsy, of course, there's pain, there's side effects, sometimes side effects on the anesthesia. Okay, ultrasound, no pain. Mammo, pain plus radiation. CT scan, no pain but with radiation, but there is some issues on the claustrophobic situations on the tube. Okay, then in terms of cost, we expect the CT scan to be the highest. Okay, so biopsy will be probably 3-piece, and then the cheapest will be the ultrasound. Okay. So all of these are readily available. Okay, so CT scan. Right away, I like to say that CT scan is usually not the first or initial test. So it's a choice among these three. But if you have to consider the highest yield as the priority, biopsy is still the first choice. But for people who don't like to go for biopsy right away, they might opt for an ultrasound first. So these are my algorithm for the indications for paraclinical diagnostic procedure. As I said, the general indications is if you want to be more definite about the uncertain clinical diagnosis, go for a paraclinical diagnostic procedure. Okay. And if there is need to be certain, to increase it up to 98 to 99% certainty, because the treatment will be extensive and mutilating, such as doing a total mastectomy, chemotherapy, and radiotherapy. Now, for specific indications, first one will be if there is uncertainty whether the dominant mass is present or not. Sometimes even the doctor cannot really say for sure whether a dominant mass is present or not, then request for an ultrasound. If there is uncertainty on whether the dominant mass now detected, whether it's malignant or not, then you can request for an ultrasound. Then the third specific indication is request for mammography only in patients 40 years old and older, not less than 40, okay, who came for a breast check and there is no palpable dominant mass. And the qualification here is the patients, some patients are very anxious of possible malignancy because of positive family history. So this could be a specific indications for doing mammography in such a subset of patients. So summary and takeaway, I just finished part 1. Part 2 will be taken care of next week. Okay. Screening for breast cancer, symptom that will lead to suspected presence of breast cancer, clinical diagnosis of breast cancer, and paraclinical diagnostic procedures for breast cancer. The takeaway in relation to patient empowerment, be always in touch with reliable medical information on fundamentals and generalities in medical management of breast cancer. Knowledge is power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of breast cancer. So with that, I end this pep talk, Fundamentals and Generalities in Medical Management of Breast Cancer, Part 1. I hope I have enlightened you to have a better understanding of the fundamentals and generalities in the medical management of breast cancer. As a reminder, please take the OLETE. Okay. The link will be placed in the chat box by Abet. Okay. And then 50 OLETE certificates is equivalent to 1 voucher for ROJoson telemedical consultation. Now we'll have a group picture before we start the question and answer portion. One. Ready? One, two, one, two.
Let's go. Yes, sir. Yes, sir.
Okay, so I don't think we have page 2. So the floor is now open for questions.
Bro, come on.
Floor is now open for questions.
Hans, can you get this?
You can put your questions in the chat box or you can raise your hands.